Is the microphone working? I think that's better. Okay. I'll ask everyone to take your seats. Welcome. It's wonderful to see such a large crowd here in person, and we have many people joining online. My first duty for today, I'm Rick Glazier. I co-lead Inspire PHC with Dr. Mike Green, and my first duty of the day is to introduce Dr. Green. He is, Mike, I'm going to have to ask you to tell us all of your various affiliations now. He's a dean of the Northern School of Medicine. He's also the president of that school. I think he's the vice provost or provost. Like at NASM, Mike is like, he leads like absolutely everything. He and I had the great pleasure of co-leading Inspire Primary Healthcare for several years now, and our founder, Moira Stewart. I haven't seen Moira today. Is she in the room? Or online, maybe? Okay. I'm sure she'll be online then. But anyway, all our kudos to Moira for kicking off this wonderful organization. So at this point, Mike is here. He's actually in Calgary at a First Ministers meeting, and he's going to join us intermittently through the day. But over to you, Mike, for welcoming remarks.
Thanks, Rick. And I'm really disappointed that I can't be with everybody in person. As you can see, it's still early in the morning here in Calgary. In my role as past president of the College of Family Physicians of Canada, I've joined the Health Ministers meeting, which is in progress here. And I will say that last night had an opportunity to speak to both Minister Jones and Deputy Minister Richardson about all the exciting things that are happening in primary care in Ontario, and also with the federal minister, Minister Michel, about some of the things that are going on across the country. So this is such an important topic for Canadians and for all of governments across the country, and the research work that is done by all of you who are researchers, and the knowledge that you gain from those of you who are here are decision makers, and the decisions you make as citizens about healthcare is also important. So I'm really glad you're all here to spend time with us today. I do want to just first acknowledge our sponsors. They're up on the screen. So Ontario Ministry of Health is core supporter for Inspire Primary Healthcare. And we have support from the Departments of Family Medicine at all of the medical schools in Ontario, as well as support from the Ontario Sports Support Unit. So thank you very much for your support for Trillium Primary Care Research Day. Can we go to the next slide, please? I just want to say this is amazing. Like, the number of attendees at this year's Trillium has been a huge jump up. You can see here the breakdown and mix of the types of attendees that we have. We have researchers, health professionals, decision makers, policy makers, trainees, students, community members, and patients. And so someone's saying not seeing the slides. Is that someone who's online? I can see mine on my online version, but I hope everybody can online. But it's a great mix of people, and the biggest numbers we've ever had at Trillium. Next slide, please. I've already acknowledged our funders. I do also want to thank our planning committee. Especially, you would have probably already met Elliot and Lynn, who've been very involved in helping get this organized, who've helped Rick and I out a lot with this. Our conference operations team, who you've probably seen out at the desk. So in addition to Elliot and Lynn, Lori and Allison, and Carolyn from OSSU, so thank you for your support. Our patient advisors who are here, so important, especially they play a big role in really helping to establish for us what are the things in the research that we're seeing that really resonate with patients. So thank you so much to our team of patient advisors, and then our moderators for the sessions, who you can see there. We have also some evaluators for our rooms, and of course to all of you who submitted abstracts and were interested in presenting, and our keynote speakers who we'll talk about in a moment. Next slide, please. And I'm hoping that someone on tech, I'm seeing that from the online participants, they're having trouble seeing the slides. For housekeeping, participants are encouraged to ask questions using the chat, and an event committee member will monitor the chat if you're online. For Twitter users, we do want to hear from you. Do use the official hashtag Trillium2025, and if you're on other social media, that would also a great place to share messages. The agenda is there in front of you. We're really excited to start the day greeting Dr. Jane Philpott, who will be introduced by Rick in more detail in a moment. I think no stranger to anybody in the primary care community, or probably in Canada, for her work both as Federal Health Minister, Dean at Queen's, where she was my boss for a number of years when I was there at Family Medicine, and now, of course, with her leadership for the Primary Care Action Table in Ontario. And she's going to talk about the importance of attaching patients to clear source of primary care. I think that will be a great talk, and some of the things that they're learning in that process. And I'm also super excited that later in the day, the other important focus on access. And so our panel on access to care and looking at, in addition to attaching patients, how do we help them get in to receive the care they need, and what are some of the things that we can do there. And we've got a great panel for you there in the afternoon. And of course, then we also have some focus on patient-oriented research, and really excited to see that at the end of the day as well. So go to the next slide. It's been an exciting year in primary care. The Primary Care Action team here in Ontario has been rolling out several rounds of support for new teams to attach new patients. There's lots of great research going on around the importance of primary care and how we do it well, and how team members all contribute to helping people get the care they need. As a research group, we've been doing work in partnership with our colleagues at the Ministry of Health and Ontario Health on how to continuously update information on who's attached and where they're receiving care. And I do want to do a special shout out to our policymaker colleagues. Since I'm not in the room, I can't see who all I need to acknowledge. I'm going to hope that Jillian Paul and her team from research branch are there, as well as some folks from primary care branch and other parts of the ministry. But it's your engagement with researchers in Ontario that really has helps to move things forward, and helps people to learn about how to make changes when they're necessary, and where to put new investments in primary care. So thanks all for being here. I hope you have a great day. I'm very disappointed that I can't be there in person. And before we move on, I would like to introduce Dr. Sarah Funnell to provide a land acknowledgement. Thanks, and I'm sorry that I have to run, but I do have a breakfast meeting that I have to get here in Calgary. Thank you.
Miigwech, Mike. Good morning, friends, former bosses. Mike's included in that list. So good morning. I'm Sarah Funnell. Some of you know me, and some of you I look forward to meeting. I'm an Indigenous primary care physician. Like yourselves, I'm engaged in research. I sometimes refer to myself as an accidental researcher. Although I'm a member of Kitigan Zibi First Nation, which just is inside what we now know as Quebec, I grew up not far from here amongst the Mississaugas of Alderville First Nation. And I'm named after my great-grandmother, who was named Sarah Doctor, and she was born in Six Nations Reserve, which is not far from here either. She was a traditional midwife on Six Nations, and she spoke 4 languages: English, Mohawk, Cayuga, and Tuscarora. I speak English, sadly. These lands that we're meeting on today are the traditional lands of the Mississaugas of the Credit, the Ishnabek, Haudenosaunee, and the Wendat people. Many who still call this place their home. This area is covered by Treaty 13 and the Williams Treaty. And today, this land is home to a vibrant and diverse population of Indigenous First Nations people, Métis people, and Inuit, each with distinct cultural traditions, practices, and strengths, yet a common experience of racism and discrimination, which still plays out today in health disparities. So acknowledgements like this remind us of our responsibility. And so there's this really wonderful Indigenous researcher named Sean Wilson, and he wrote some really cool books with others, of course. There's Research as Reconciliation, Research as Ceremony. In one of his books, he quotes Spider-Man, which I really love because one of my kids loves Spider-Man. He writes, "With great power comes great responsibility." I've also heard him say, if research hasn't changed you, then you didn't do it right. And I can tell you that my research journey as an accidental researcher in Indigenous health research has certainly changed me, and it's been very challenging. So throughout the day, as you hear from each other, I encourage you to reflect on your great power as researchers and how it's changed you, and the potential it has to improve the care we provide our patients, our communities, and particularly First Nations people, Inuit people, and Métis people. And with that, I'll hand it back to Rick to continue the day. Miigwech.
Thanks very much, Sarah. Before I introduce our keynote speaker, I'm going to shamelessly plug a research funding opportunity and a practice improvement opportunity because I have the opportunity to be here on the podium, so I'm going to take that prerogative. And I'm delighted to be joined by Drs. Sabrina Wong and O'Neill Bhattacharya at the Special Reserve table over here. We've got wonderful participation from across the country. So Sabrina is based in Vancouver. I see folks here from Halifax and from Quebec and from many other places. So that's a bit of a departure this year to have more pan-Canadian reach, which is fantastic. And this is a pan-Canadian opportunity that we're going to be talking to you about just very briefly, and then I promise I will introduce our keynote speaker right after that. So if I could have, actually I think I can advance the slides, yeah, okay. So there we are. The slides are like way over there. Okay. So what I'm going to tell you about is that the Canadian Institutes of Health Research, CHR, and Healthcare Excellence Canada, which is one of the pan-Canadian health organizations, are partnering to advance the evidence-informed implementation of primary care innovations through Healthcare Excellence Canada's Care Forward initiative. So if you remember nothing else from what I said right now this morning, is that you should go if you can, and if you're a clinician, or you know a clinician, or you work in a clinic, or you know of someone who works in a clinic, get them to sign up for Care Forward. Go on the website at Healthcare Excellence Canada, sign up for Care Forward, and make sure you check the box that says, I want to participate in research. If you are a researcher, go talk to all those folks. If you're a patient or a policymaker, go talk to all those folks. So the deadline for signing up for this wave, so this is a practice improvement initiative that, so it's kind of a quality improvement, practice improvement initiative, quite a bit of which is focused on primary care, timely access to care, integrated care, avoiding emergency department visits, all of the things that many of us are engaged in and care about and worry about. So there are two things that can happen here, two things that we'll advise about. One is to tell all the clinicians, if you are a clinician, tell your colleagues, tell everybody. It's only until the end of the month. It's only until the end of October, October 31st, to sign up for Care Forward. It doesn't mean that people can't participate as a researcher later, but the practices have to sign up between now and then for this quality improvement. And then we as researchers will be able, the research community across Canada will be able to participate with the initiative as well. So the idea here is that we're layering research together with quality improvement, which we did earlier a few years ago at the height of the pandemic in long-term care. Healthcare Excellence Canada had a huge initiative called LTC Plus, or Long-Term Care Plus. They reached 1,800 long-term care homes, and we were able to layer 22 implementation science teams on top of that. So I'm going to advance one more. So we've got the CPCRN slide up, don't we? Yeah, maybe we can go back to, yeah, there we go. That's what I wanted to speak to, was actually the Care Forward slide. Okay. So what's on there is what I have already told you about. So this is about implementation science and rapid research response. So this is to support real-time primary care practice and policy change across Canada, complement Healthcare Excellence Canada's quality improvement. They're going to provide coaching supports, webinars. There's some funding involved around the practice improvement issues. And the research is going to be layered on around implementation science and implementation support. We're really excited about this initiative, and just taking this opportunity to plug it a little bit, given the timeliness. So what I'd like you to do is take a picture of this QR code, and this will take you to the Care Forward website, where you and colleagues can sign up. And again, there's no cost to sign up. There's support that's involved. And then check off that you're also interested in research. So this is the practice improvement part. Check off that you're also interested in the research component, and the matchmaking will happen afterwards. I don't know, O'Neill and Sabrina, if one of you or both want to speak briefly to CPCRN? And then we'll go to the slide that's actually about CPCRN, if we can. Let's see. No, let's see. How do we get back to that? There we go. Okay.
All right.
Okay.
Thank you for the plug, and we'll keep it short so we can get to speak. Get to hear Jane speak. So Sabrina and I have been co-leading a Canadian Primary Care Research Network. We recently came together with the Canadian Primary Care Trials Network and the Canadian Primary Care Sentinel Surveillance Network to build a consortium. We had a sort of first meeting back in November of last year in Quebec City to plan it out. And we have a sort of launch activity in Manitoba, in Winnipeg at FMF. But essentially, the idea, if you can see here, there's patients at the center. There's a series of pillars related to research and innovation, patient engagement, clinical trials, practice-based research and learning networks. And so essentially, putting these different pillars together with different leads to bring the primary care community together across Canada. We have provincial leads from every province and territory coming together in a range of activities, so watch for this. And there's a little QR code you can scan as well, and more to follow on that. But we will also be supporting the Care Forward initiative with leads across every province to support local teams.
Thanks very much, O'Neill. So the reason that I'm here plugging this for you is, first of all, the research community and the primary care community love an opportunity, right? And I think one of the themes for today is going to be optimism. So I'm also serving in the role of scientific director at CHR of the Institute of Health Services and Policy Research, ably joined by my associate director, Dr. Meg McMahon, who's with us today. And our president at CHR, Dr. Paul Hébert, very early in his tenure, earlier this year, came up to me and said, "Rick, primary care has to be a top priority at CHR." Those words were never spoken in the previous 25 years, I can tell you. So I am feeling, from all of my roles in Ontario with Inspire, in my clinical practice, and at CHR, a tremendous sense of optimism. And we have a speaker who I'm about to introduce, who carries that optimism and who carries that energy and who carries that enthusiasm and leadership in a way that none of us have really ever seen before. There happens to be a policy environment in Ontario and in many other provinces across the country now in reaction to big challenges. Some would call it a crisis. Others don't like to use that word, but we know primary care has been struggling. We know between 5 and 6.5 million people don't have access to a regular primary care provider. We know there's been tremendous progress, though, and I want to shout out to Tara Kieran, who's here in the front row, for her work on Our Care, which has actually led in Ontario to legislation. I'm not aware that this has ever happened before. The Primary Care Act has been passed, and every item in that act completely mirrors the Our Care standard. So kudos for you, Tara, and all the work you're doing, looking across Canada and in Europe and elsewhere in the world for all the best practices, and your podcast also a shout out for that. So just to say that I'm feeling way more optimistic. We have a large budget, we have a fantastic leader and a fantastic team, and everybody working across Ontario and many other initiatives across the country to advance primary care attachment and access, which is that, and that's the theme of our day today, is primary care attachment and access. So I'm going to introduce our speaker, who needs no introduction and who Mike basically already introduced. So Dr. Jane Philpott has been a family physician for over 30 years, including a decade in Niger in West Africa. All of you know she's a former health minister of Canada. She was the chief of family medicine at Markham Stouffville Hospital. She has been the dean of the Faculty of Health Sciences at Queen's University. So pretty much Jane has been everybody's boss at one point or another. And I have other bosses of mine in the room too, you know, when I look around, there are many. She's currently the chair of the Primary Care Action Team. So Jane, we want to give you the maximum time possible. And so with a warm welcome, I want to really thank Dr. Jane Philpott for joining us this morning.
Thanks very much, Rick, and good morning, everyone. What a wonderful big room this is. It's so great to see such a big in-person crowd, and hello to all those who are online. I'm not sure where I look at you. There looks like there's a camera back there, so I'll say hi to the online folks, but really glad that everybody made the time to come out today, and looking forward to the day here. I was saying to some of the people that I was sitting with at the table, there's always a sense when you get to do these things, like give a keynote address at a gathering like this, that there's always a fear in the back of my mind that I will not say anything that you did not already know before you came here. So I hope that there'll be something that will at least reaffirm what you've been thinking about and give you some ideas about how we can continue this exciting journey that we're on together to build health systems in this country that are deeply founded in primary care. And I would say part of that imposter syndrome that I feel when I'm speaking to a crowd of like this is that this is a research day, and I am not a researcher. I have done some small R research over my life, enough to know how hard it is and how important it is. But I will come to you today as a person who is very much a knowledge user. And I can tell you that I have used the knowledge that people in this room have produced in multiple ways on multiple occasions, and am very grateful for it. So thank you for inviting a knowledge user to be able to give your opening address. And I'm sure that you're going to hear from some fantastic researchers as the day goes on. When Rick and team reached out to me and gave me a fair bit of wide berth as to what I would talk about today, they said they wanted to hear about attachment strategies, so we'll throw in a bit of that. They wanted to hear what it's like to set objectives for the work that we're doing at the Primary Care Action Team, so you'll hear some of that. And then they were very interested in what we have learned so far, and so I'm actually going to dedicate the latter half of my remarks to lessons learned in the journey over the last year or so. Before I go any further, I just want to again thank all of the sponsors for this, and particularly to the departments of family medicine and family and community medicine across the province. It says a lot that every one of those departments continues to contribute to this work. University budgets, if you hadn't already heard, are extremely strained, and there is enormous pressure to take things out of your budget. The fact that these 6, now 7 chairs of family medicine across the province have said, no, we are going to continue to contribute to this work, it is deeply important to us, speaks to the strength of the chairs that we have in the province now. So a big shout out to them and a big thank you to each of them. Okay, so I want to take you back to about a year ago. It was literally a year ago, the Friday of the 3rd week of October, that I had the opportunity to have a cup of coffee with Premier Ford. They were about to make an announcement on the following Monday that they were going to start something called the Primary Care Action Team. And his team said, it's very important that the two of you sit down together over a cup of coffee, look each other in the eye, and agree upon what you're committing to one another on. I'll give you the whole story of that some other time, but it was a lovely conversation, and I think it is really a remarkable place that we have found ourselves in, that the government of the province of Ontario realized the kinds of things that Rick was talking about, that there was a massive gap in our healthcare system, that there were needs that were not being addressed, and those needs came in the form of people who did not have a primary care home. And the Premier himself and his team had recognized a very serious problem. It speaks to the power of politicians knocking on doors and hearing directly from the people of Ontario who said, my most important thing is that I don't have a family doctor. And you don't always realize that those conversations will lead a government to take action, but it is what people say on the ground that drives what politicians will do. And if they hear that from enough people, they want to do something about it. Often there's no solution available to the problems that politicians hear at the door. The good news, thanks to the research that many people in this room and many others who have gone before have done, is that we had a solution to this problem that was felt by the people of Ontario. That solution was known to every one of you long before a year ago. You knew that we had not properly built our healthcare system in this province on primary care. And you also knew that countries, provinces, regions who build their health systems on primary care will get the best health outcomes at the most affordable cost in a way that is both equitable and accessible. That's been deeply ingrained, I think, in everybody in this room. And so we had a solution to offer this government and other governments who are facing the same challenges in terms of lack of access to primary care. And that delightful thing happened where a group of people who had the power to do something about it realized not only that they had a big gap or a big problem, but there was actually a potential solution out there. And somehow they found their way to Jane Philpott, who seemed to think that she had some idea how you would put that solution into action. And so the Premier looked me in the eye and he said, Jane, everybody in the province needs a family doctor. And I said, I agree, everybody in the province needs to have access to primary care in the form of a family doctor or a primary care nurse practitioner or a primary care home of some form, a place where they can go as a front door to the healthcare system. And the other thing the Premier said to me was, Jane, I don't want you to write a report. There have been enough reports written. That's kind of refreshing because most governments want you just to write a report. He said, I want you to go out there and fix the problem. And so I said, that's great. I'm going to need a bit of cash. And we had a very clear conversation about the fact that there were going to need to be some investments up front. I assured him and his team that if we do this right, that we will actually save money in the end, and that doesn't take a whole lot of brains to figure that out. That's very obvious to anybody who has thought about at what stage you should intervene in health and health outcomes, that the more upstream we can go in terms of our interventions, the better value we will get for money. But it takes a shifting of budgets and it takes some initial investments to be able to get started in that. And so I was clear about the investment that needed to happen. And so I was given on that day a mandate to say, we're going to launch the Primary Care Action Team. We want you to go out there and make sure every single person in this province of Ontario has access to primary care. That was the mandate in a very simple statement. What I heard underneath that was we need to build a primary care system, because there have been governments in the past that have tried to say, let's just divide up the number of people who aren't attached to care by the number of family doctors in our province, and let's just say that they're all attached because we'll just give them each a few hundred more. That's not sustainable attachment. We need to be able to build a system such that when I decide someday to retire and put my feet up, or whatever else I decide to do with the rest of my life, and Liz and others who are helping this have moved on to other things, that this will be a system that will last for the ages. This is a generational change in the way we're going to deliver care here in Ontario and hopefully elsewhere. We are building a system for primary care. So we are moving at what I now call the speed of need. We are recognizing that there's an enormous amount of work to do to create a primary care system, and you can't do it all at once. And so we had to do some pretty radical prioritization about how we were going to actually make this happen, so that we would get care out to people as quickly as possible. And I knew that one of the things that that would make a big difference was to be able to support family doctors on the ground, to support primary care teams, and to be able to give them additional resources as quickly as possible, to share the load, because the load is enormous. And that if we added resources in the form of team-based primary care, that would actually be a way that we could find that our family doctors and nurse practitioners could be able to do the work that they are best able to do and share things that could be shared with others in terms of work. And I'm so glad that you're calling this conference Attachment and Access. People often say to us when they hear about the work that we are doing, which is focused relentlessly on attachment, they say, but what about access? But what about quality? But what about comprehensiveness? All of those things are important. So to say that we are relentlessly focusing on attachment is not to say that all those other things aren't absolutely essential and are part of what attachment means. You have to be attached to accessible care. You have to be attached to inclusive care. But the first thing we need to do is to build a system so that everyone will actually be attached. And so that is what we have decided to do. We're now 10.5 months into the work of the Primary Care Action Team. I think we have made progress, and I'm going to tell you a little bit about the signs of progress that we've seen along the way. There is a lot more to do, but it's been a really exciting journey that we've had together. And Rick, the thing that makes me particularly happy is that there is this sense that we are moving from crisis to hope, or crisis to optimism. And I think we were overdue for that sense of shift in the sentiments of what it means to be a primary care clinician and on a primary care team. So that day that the Premier spoke to me, he said, I'll give you 100 days to write a plan. I need a plan. I need to know what you're going to do. So we started our team, and I keep looking at Liz because she's been involved in this right from the start. We have a little office in Whitney Block, which is this fascinating building on the east side of Queen's Park Circle. And we wrote up at on our whiteboard 100 days, and then we started writing 99, 98, and how many days did we have left for the plan? And a week or two in, somebody from the Premier's office popped by and said, might need to have that plan a bit sooner than 100 days. So we were like, okay, well, let's see if we can have it ready. And we had the exact date that we thought this plan was going to be delivered on. And as the weeks went by, we kept hearing maybe it's going to be a little less and a little less because maybe there's going to be an election. In the end, we had 55 days to develop a plan. Again, the good news was it wasn't like we were creating something that no one had thought about before. We have an enormous body of research that tells us what good primary care is. We have fantastic research from the mouths of Canadians themselves through the Our Care study, who spoke to what primary care should be in the minds of people. And so we were able to draw on that, as well as many, many international examples, to determine what that plan would look like. And 2 days before we had a provincial election here in Ontario, the initial plan was announced. It was announced along with an investment of $1.8 billion over the first 3 years, which is the biggest single investment in primary care in Canadian history. So we were extremely excited about that. You know, it's one thing for governments to say we're going to attach everyone to care, but when a government also says, and we're going to pay the amount of money that it deserves in order for that to be possible, that makes people really believe that this is going to happen. And we had 3 pillars to that plan, which have been sustained to this day. One is the investment in team-based care, which you will have heard hopefully something about. The second pillar is around the digital aspect of what primary care needs and the data behind that. And the third pillar is the workforce. How are we going to make sure that we build and maintain a robust workforce, give them the supports that they need, help them to understand how they can work best together. So the biggest focus, I will say, and it's probably been evident to some of you in the first little while, was on the rollout of that team-based care. Again, you know, not always in a way that was completely fully planned out, but I said we need to get money out the door quickly, because I know that even once people know that they have resources to hire nurses, to hire social workers, to put a team together, it takes time for that to happen. The sooner we can get those resources out to people who will have them, the sooner they can start taking more patients into their practice. And so we launched very, very quickly a first round of funding. There had been, in Ontario, just for those of you who aren't from Ontario, about a year and a bit before that, there had been a previous investment in team-based primary care, which was good. It had been about 12 years at that point since there had been any substantial investments in team-based primary care. So in 2024, when there was initially a rollout of funding, that was perceived as a great thing for all of us in Ontario. But this was a chance to do so in a little bit more, in a way that was a little bit more structured and evidence-informed in terms of how we did it. And I will say a little bit about that in a moment, but just wanted to also comment on the fact that we are now in our second round of rollout of funding. Those of you who are in Ontario, I hope you know about it. There's $250 million on the table, not a small sum of money that is available for teams to be able to do that work. And again, just in case this is not entirely clear, this is not just funding to say, go out there and hire a bunch more people for your team. This is money to support team-based primary care for the purpose of attaching people to primary care, for going out and purposefully finding the people in your community who don't have an ongoing relationship with a primary care clinician or team, so that they will be attached to care. That is the number one marker that we are looking for. We will give you more nurses, we will give you more social workers, we will give you supports for your medical office assistants and your care connectors and navigators in your teams. And it is for the purpose that you will free up the most responsible clinicians, the family doctors, and the nurse practitioners to take on more patients. So finding ways to say, let's grow the workforce so that you can care for more people in your communities. It has been absolutely fascinating to see the results of these, to see the incredible collaborations. It's been adopted quickly and happily by some parts of the province. Others have been still, I would say, a little more skeptical about whether this is going to work. But in general, we have seen enormously positive collaborations. I never thought I would see the day where doctors who were part of perhaps family health groups or family health organizations collaborating alongside community health centers and other family health teams and saying, if we all get together, what more could we do together? How can I help you so that you can help more patients? And that has definitely been happening in a powerful way. Three of the strategies that we have used in the rollout of these teams that I think is different from previous works and from the original expressions of interest process that took place a couple of years ago. One, it was highly data-driven, and I'm really proud of the fact that we have tried to embed data and evidence in every piece of this work. This brings me very much to the incredible work of Inspire, and Rick will know that it was probably the first week that we started when I spoke to our folks in the Digital and Analytics Department of the Ministry of Health to say, I need to know as close as possible to exact how many people do not have a primary care home in this province. And I need to know where they are, and I need to know who they are, because that's how we're going to figure out where to make those investments. And we knew that Inspire had done an incredible amount of work, and they had collaborated, I think, to a significant extent with colleagues inside the ministry. But we really encouraged our colleagues to collaborate deeply with researchers at Inspire to make sure that we were agreed upon our methodology. Not to say that government dictates what researchers' methodology is or vice versa, but to say it would be really helpful if we were using as close as possible to the same approach to determining what that number is. And there was a fantastic exercise of, here's how we measure it. These are the patients that we know for sure are attached to primary care because they have enrolled in a patient enrollment model. These are the patients that we know are people that we know that are going to community health centers or nurse practitioner clinics. Then there's this whole group of people who see the same doctor on a regular basis, but they've never signed an enrollment form, but it seems that they have a continuous relationship with that doctor. So those people we believe to be attached. And then there's this big bunch of people that we don't see any evidence that they're seeing anybody on a regular basis. And those people we are going to consider unattached. So that work was, I think, a really excellent exercise. And we have continued over the time to make sure that we are looking at those numbers very closely. It frustrates me that Stats Canada can't keep up to us and give us our denominator as fast as I would like it. I'm going to have a conversation with them. But we have to wait for Stats Canada to give us our full denominator of what the population of Ontario is before we can actually determine what the percentage are of people who are unattached. So we only get updates on a quarterly basis on that. But I can tell you the good news, which I'm happy to report to you now, is that I now know that as of March 31st, I recognize that was a while ago, I'm blaming StatsCan. As of that date, the number of people that we believe to be unattached in the province is 2,015,464. That's the exact number according to our calculations. That's a lot of people in Ontario. It's not as high as some of the numbers that you've been hearing. We believe that is the best and most accurate number that we can determine. But whatever the number is, it's very, very big, and that's the number that we're working with. We now have gone out and, again, working alongside researchers, looked at exactly where each of those 2 million people are. Where are they clustered in groups? Where are their neighborhoods where they are needing attachment to care? And on our first rollout of the opportunity for funding, we gave that information at the level of the postal code zones, the forward sortation areas, and said, here's what we think are the people that are unattached in your postal code zone. It drove a few people slightly crazy because postal code zones don't line up with other things like teams and Ontario Health Teams, etc. But we, in our short period of time, said that's the information we've got right now. We're going to make it better. And I'm really happy to say that now that we're in the second round of funding, not only have we made it better, but we have given that direct information to every Ontario Health Team in the province. So they have the numbers of unattached according to the postal code zone, the forward sortation area. They have it according to census subdivisions, and they have the information according to aggregate dissemination areas. I've learned all my terminology of censuses, etc. So we have then said, we need you to attach according to this. And if you've already got 2 primary care teams in an area where your attachment numbers are very low, well, they should be able to cover that. But look at this part of your community over here. There's no primary care team there, and yet there are 18,000 people maybe who are not attached to primary care. That's where we want to make an investment. So it's been a heavily data-driven exercise, and I expect that you've been part of that. If you haven't been part of it, I hope you are going to become part of it very soon. This has allowed us to do the second thing, which I think has really been important, is to think about geographic-based care. And this is the part that makes me really excited, because I think about the work that we have all somewhat thought of over time, and certainly have looked at other countries to see these geographic-based models of primary care. But now we are specifically asking people to think about geographic zones and to think about what would it be like if you could say to everyone in your neighborhood, this is a primary care home that will provide you access to care when you need it and in a timely way. And the third thing that was a feature of the call for proposals, it has been the use of Ontario Health Teams. And I won't go into a whole lot of detail on this for those of you who are from outside of Ontario. It's a relatively recent phenomenon as an organizational structure in Ontario. I think it's still kind of forming itself along the way, and that form is following function. And in this case, one of the functions that have been given to Ontario Health Teams now is to help us organize because they see and understand communities as close to the ground as possible. They're leveled down from the Ontario Health Agency and the Ontario Health Regions to be able to start to look at where are the needs and gaps in our communities. And I would say they are at varying levels of maturity, but some of them are doing really extraordinary work, are way, way ahead of what we've been thinking at the Primary Care Action Team, which is great. Others, I would say, are still trying to figure out what it means to work together and who are the primary care clinicians that they need to work with. But everywhere in this province, those Ontario Health Teams and their primary care networks are working really hard to be able to figure this out. Let me just tell you before I move into lessons learned, just a few other highlights of things that I'm excited about and just wanted to make sure that you are aware of. One, Rick has already spoken of, which is the legislation. When we look to countries around the world who have robust systems of primary care, not only do we learn things from them, like the fact that they organize according to geography and neighborhoods, but we see that many of them are founded on legislation. In many cases, of course, that's federal legislation, and one of our hopes is that someday there will be federal legislation on primary care, but we decided that this would be a great opportunity in Ontario to advise the government that there should be provincial legislation. When we proposed it to government, I wasn't actually sure how well it would land, but I was delighted when this government returned re-elected in the spring and said we're going to table primary care legislation, and asked for advice from our team as to what that would look like. It was pretty handy, I have to tell you, to have known that some people had done some research and that they had spoken to 10,000 Canadians, and they spent about 10,000 hours doing so, and they heard from the voices of the people themselves as to what they thought a robust system of primary care should look like. And I'm speaking, of course, to the Our Care study led by Tara Kieran and her colleagues, of which I'm sure there are many of you across the room who contributed to that research. What an exciting opportunity, Rick, wasn't it? To imagine that we could go from research, not just into practice, but research into the law of the land. And it is now the law of the land here in Ontario for this government and every future government to build and maintain a primary care system, and that primary care system must meet a set of objectives. And the 6 objectives of the system are, as Rick said, completely aligned to the Our Care standard. Number 1, it has to be province-wide. No one is left behind. It is a universal system for primary care, just as we have universal systems for public education. Number 2, that it is a connected system, that primary care should not operate in a silo, but it must be connected to other health and social services in the communities where it's delivering care. Thirdly, that it must be convenient. And this is a really interesting word. This is a word that if you listen to the language of the Government of Ontario, the government is very committed to convenience. But it's actually a really great word because it speaks to the second part of your theme today, is access. It doesn't do you any good to be attached in theory to a primary care clinician if you can't get an appointment with them. And if you can't get an appointment in a convenient way when you and your family are able to be seen. And so that commitment to timely access is written into the legislation. Fourthly, it needs to be an inclusive primary care system, that it has to respect the laws of the land in terms of not discriminating against anyone for any reason at all, that it needs to be an equitable system of primary care. Fifthly, we recommended the word empowerment, which, again, I love the fact that that was the word that was chosen. It came from the recommendation that the people of Canada said they want access to their primary care information. And in our advice, we suggested the word empowerment because what that actually does is empowers patients when they can get that kind of access to their own information. There should be a digitally connected system to which patients have access. And sixthly, that the system needs to be responsive, that there needs to be, some might use the accountability, but again, I like the word responsive because it speaks to the fact that there will be regular reporting on whether the system is delivering what it promised to deliver, and that it will respond to the needs of the communities that it serves. So, exciting opportunity for us in Ontario. Two more highlights. I wanted to just make sure that you all know, I'm so happy that this happened, that we are going to be building more primary care teaching clinics in the province. You all are the people that are helping us to train the next generation of family doctors, nurse practitioners, and others on the primary care team. You can't train them without a place to train them, and that has classically taken place, although not always, in dedicated family medicine teaching units. We've changed the terminology a little bit to be a more inclusive terminology and to speak to the fact that they aren't just units, they are clinics. These are clinical learning spaces. And so the government has elected to invest up to $300 million in building 17 primary care teaching clinics in the province, which hopefully we will start to see the doors of those clinics opening very soon. I know the chairs of family medicine are under enormous pressure to figure out how they can meet the demands to train more family doctors. And the final thing that I wanted to add as a highlight is the work that we've done on Healthcare Connect, in part because this is one of my pitches to you to ask for your help. So we had this system in Ontario that was essentially intended to be a matching system. It was designed as a program in 2009. It served some purpose along the way, but I would say, like many systems and government programs over time, didn't always have the attention focused on it. And over time, the number of people that were putting their names on this Healthcare Connect waitlist was growing like this, and the number of patients that were being attached to care was staying pretty steady like this. And so that gap was growing to the point that at the beginning of this year, on January 1st, there were 235,000 people whose names were on that Healthcare Connect waitlist, some of them having waited as long as 5 or 10 years for attachment to care. Again, kudos to the government who said, it's not right that there's a wait list on which people put their names and they don't get attached to care. In fact, they get letters saying, we still have your name on the wait list. That's all that seemed to happen. And so they asked us in our team, what can you do about the Healthcare Connect wait list? Some of you might be cursing me that I said, I think we can clear that list. I think that 235,000 people, if you give me about a year to work with my team and all the people across the province, I think we can find a way to get all those people attached to care. And so we made, on behalf of all of us, a commitment to make sure that those 235,000 people are all attached to primary care by next spring. It's a bit of a wild commitment, but I have to say the system has turned itself on in a really powerful way because of the work of a lot of people who suddenly realized, oh, we're really going to do this. This is a serious commitment. And hopefully some of you saw the news this week that we reached a milestone that 50% of those names have been reduced off the list. That has come from a few different kinds of processes, and I won't go into all the details of it, but the first thing that we did was we said we need to verify that list. Are those people still alive? Or do they still need attachment to primary care? The care connectors across this province have made an enormous, I actually meant to look this up this morning, what the number of phone calls and outreaches, but they've been reaching out by phone, by text, by email, by letter, trying to reach out to those 235,000 people. I'm very happy to say that of the 50% that have been cleared off the list, 85% have been cleared off the list because they've been attached to primary care, which is pretty amazing. Let's celebrate the work that happened. The other 15%, either the person, a very small number were deceased actually, which was kind of good news, I guess. A few had moved out of province. There are a few reasons why others' names were not necessarily attached. But there was a process of meticulous organization that it took for that thing to happen and rapid cycles of improvement. And I could go on at great length telling you the details, but you would love it. You would love the fact that every Monday afternoon, I get an email in my inbox that tells me exactly how many phone calls I've made and how many people have been attached to care and where they've been attached to care. And in every postal code zone, how many people are still on the Healthcare Connect wait list and how many of them have been referred to a clinician. And it is a fascinating exercise in trying to find out how we can make sure that these people are attached to care. This is not the only way to find people who need primary care, and I just want to shout out to the fact that we get that there are people who can't find their way to Healthcare Connect, have never heard of Healthcare Connect, don't like putting their name on a list. We have to have other strategies for reaching to those people. But the 235,000 people put their name on a list believing that something would happen and that they would get attached to care, and they deserve it, and some of them are the people who need care the most in this province. It's going to be really hard when we get down to those last few people on the list. There are some people on that list for whom there is a difficult reason why they are not attached to primary care. They've maybe had a clinician, been discharged from their clinician for all kinds of reasons, or no clinician, when they looked at that history of that person, wanted to take them into care. Here's where I really need your help. Can you help me with the most difficult to attach people and find a way to figure out who in your communities can call their care connector and say, I will take 5 people from the list, and I will take the 5 most complex people. Or maybe it's only 2. Or maybe you're a new clinician and you can take 20 difficult, complex patients and a whole bunch more less complex patients. But we've got to find a way to care for people with complexity, and we can't just leave their names on a list to languish. So that would be one area that I would love to see your help with. Rick, I'm going to fly through some lessons because have I got time for that? Okay, let's fly through some lessons learned. What have I learned in this, or what have we learned in this? Number one, whatever you are setting out to do, it's really helpful to have clear and ambitious goals. So set big goals for yourself. It was perhaps a little overambitious to say we could clear that list in a year, but if we hadn't said that, then there's a whole lot of people that might not have gotten attached to care. So set big goals and use very strict deadlines, and push your deadlines. People who, I don't know how many people are listening in who are from the ministry or even from OH who might say, honestly, that woman and her deadlines. Because they always come to me with, here's what the timeline is going to be, and I'm like, we need to do that faster. That is not fast enough. There's got to be a way that we can shorten that. How can we line things up so that we can get there more quickly? But you've got to mean what you say when you make promises like this. So when I get those reports on Monday afternoon, a few weeks ago I was getting reports back that were saying postal code XOX or whatever it was, they have 5,000 people on their list, or they have 2,000 people on their list. They have determined that they're not going to be able to meet the goal of clearing it by next spring. Like, that was not an option. That is not an option to just say that you can't do it. they said, well, there's just nobody that can take care. I'm like, have you knocked on the door of every family doctor's office in your community? And if not, and if you're not able to do it, I'm going to set aside a day. Liz knows this because I'm like, I'm getting in my car. I'm going on Google. I'm going to find the names of every family doctor, and I'm going to show up with donuts and coffee, and I'm going to say, what can I do to help you so that you could take care of a few more people? Because it is not an option to not clear this list. And so they said, whoa, they're a bit, makes everybody a bit nervous when I threaten to do these things. They're like, oh, just give us a little bit longer. And I'm really happy that one of those places that when the report came 2 weeks later, it was like, oh, they found some capacity. This is great. There's a way to be able to clear the list. So setting deadlines and making sure people know that you mean it is really important, and celebrating successes. And we've certainly been celebrating a lot this week that that team of people have reached the 50% milestone. Second is when someone gives you an opportunity to create something that's big and important and supplies you with not all the tools, but some pretty good, serious tools, you've just got to get started. Even though it's going to be messy. And we've had to deal with a lot of messiness, and messiness makes some people very uncomfortable. But messiness is what we do. It's what researchers do. They build a plan, they test their plan in real life, they see what they've learned from it, and then they make their system better. So when we rolled out that first round of funding, we know that not everybody liked having it organized by postal code zones, and that postal code zones make no sense in Northern Ontario, for example, but that was as far as we could get on our plan, and we needed to get that opportunity out the door. And the next time we made it better, and we heard what people said and improved the system. So iterate continuously, but get started. I'm a big believer in active experimentation as the most important part of the learning cycle, that you have to actually experiment, and that's the best way to learn. So finding ways to live with that messiness and helping your teams to live with that messiness. And I know that we have not figured out how to work together in teams properly, but some people are figuring it out, and we're learning from those who have figured it out, and eventually we're all going to figure it out and have a better way to share our work amongst ourselves. I learned recently that Thomas Edison described the people in his lab as muckers. Did you know that? I love this term. It's one of my new favorite terms. He called his team the team of muckers, and they just mucked about until they found ways to be able to create light. And so we're mucking about in trying to create a primary care system, and we're kind of learning as we go and making a little mistake here and there, but all roughly headed in the same direction, giving each other a lot of berth for not getting it perfect the first time so that we can eventually get to the same direction. Number 3 is knowing your facts. I think I don't need to say that in this room, but I will just say that it is so important to follow the data. And it's so important to let the people on your team know that you are following the data. A few weeks ago, I'm telling lots of stories out of school, but a few weeks ago, so when I got my Monday morning reports or Monday afternoon reports on the Healthcare Connect waitlist, I used to respond to Rosemary Hannum on our team, who's an amazing, amazing support for our team. And I would say to Rosemary, well, I noticed this and I noticed that, and then Rosemary would share out, well, this is what Jane thinks about this and that. And then one of our officials said, why don't you just reply all to the whole chain that got the report. I was really nervous, I tell you, but I'm like, do they really want to hear what I have to say? Because there's like 65 people on that email thing, but I did it one week, and whoa, it was just, it turned a whole system on, because what it did was it showed everybody on that email chain that I actually read every line in the PowerPoint, and I read every data point in the PowerPoint, and I had questions about many of them, and that we were actually looking at this, which helped people to first of all realize that their work was super valuable, that they weren't preparing these PowerPoints with a whole bunch of data that nobody actually looked at, but that it was expected that this data was for a purpose, and it was for the purpose of improvement. So examining your data, I think, is absolutely key. That's the quantitative inquiry that's necessary for delivering on a project like this. The fourth part is the qualitative inquiry, just asking a lot of questions. Governments are really good at saying that things are great and this is not any particular government necessarily, but there is kind of a culture that's built into bureaucracy, et cetera, to say, we're doing this thing and it's really good and everything's going to be just fine. And there's a desire to believe that everything is going really great, and you have to try not to discourage people, but I always look under the surface to say, is it actually really great? And are we actually doing the thing that we said we were going to do? So, we're supposedly creating this wonderful database in Ontario where all of our health information is pouring into this database, the Provincial Electronic Health Record. And there's a lot of great things that have been said about that for a long time, but I'm like, are we really putting that data into that database? And can I see the list of what's actually in that database now? And if we haven't got this piece of data into that database, what is the reason for it? So asking a whole lot of questions, not in a way that makes anybody feel like you're blaming them, but saying to them, if you've got a roadblock, let's clear the roadblock. And if you don't have the authority to do what you think needs to be done, then who has that authority? And have you asked them to get you that authority? So there's a whole lot of things like this that happen inside systems, whether they're government systems or university systems or others, where people believe they don't have the authority to make changes, but they need to be empowered to find out who does have that authority. When people are under stress, one of the most unhelpful things is feeling like you have no power to change the circumstances and that you are simply a victim of the circumstances around you. And in a time where people are feeling burned out and stressed in primary care, we have to help people find their agency, to find the fact that there are ways to make changes. And most of us have the authority to change a few things, and if not, we know who made those rules that are not working for us, and we can find a way to change those rules. So helping people figure out what levers they can reach, and if they can't reach those levers, who holds the levers so that they can exercise that agency. And the fifth thing that I think has been really helpful for us is making sure that we listen to and empower the people who know the truth. And that is, in the case of primary care and building a primary care system, it is the people on the front lines of care, and it is the people who are behind the scenes in all of these systems. There are a lot of people who have really great ideas whose voices aren't heard. And one of the things that I think both Liz and I are able to bring to the primary care action team is we have a lot of spies. So I can't just pretend that things are working well when I have people like my daughter, who's a family doctor in Belleville, and Kim Morrison, my friend in Napanee, calling me up and saying, that thing that you guys say you're doing, it's not working. That announcement that you made, it's not real yet. So all of these people, and I get people find ways to send me messages, and I'm sure it drives the other officials crazy. It's like, I got a direct message on LinkedIn who said that they didn't get the information that they needed to be able to organize their attachment. Anyway, but then suddenly it happens and they get this person their attachment, and it helps me to know what's actually happening on the ground. And I think that's something that is a great opportunity that we have right now, is that we've got people that are helping to organize this system who, I don't get to work on the front lines of care like I used to, although I miss it very much, but I know a heck of a lot of people who do, and those people seem to not be afraid to tell me when it's working and when it isn't, and then I can tell the system and say, it's not actually working the way that we said it was working, and so let's actually get to the bottom of this. One of the other things that does is helps those people on the front lines. And when I say front lines, I don't just mean front lines, clinical front lines, but it's like the front lines of bureaucracy and the front lines of universities and the front lines of hospitals, the people way behind the scenes that feel unseen, undervalued, underappreciated, the people on our teams, many of whom feel unseen and unappreciated. In times of stress, most people feel unappreciated and unseen. And the more that we can say, I see what you're doing, I need your information about what's working and what isn't, I value that information, and I'm going to make changes to the system based on the information that I learned from you. And it seems to really help us a lot. So I started with the fact that when someone gives you a big job to do. You should just get started. So I bet many of you are in the process of jobs that you're underway on. I hope that you have already started, and if not, get going. Don't worry if you make mistakes, if it gets messy and complicated, and if not everybody agrees entirely with the approach, but get yourself started and keep going. If you have an opportunity to participate in one of our calls for proposal, please do so. If you don't know about them, then please find out where your primary care network is. If you're in Ontario or your Ontario health team, please let them know that you are available and that you have contact with the most important resource, which is the resources of clinicians and teams who can care for patients out there. So please get involved to the extent you can. Please be as ambitious as possible. We love when we see the proposals and they're like, we have a plan, we've got 18,000 people and we're going to attach 5,000 this year and whatever it is, so it adds up to 18,000. We've organized ourselves in neighborhoods, and it's so exciting when we see these kinds of ambitious plans. You will, like we are, learn along the way. It's not always easy. Not everybody agrees. It gets a bit messy and complicated, but you will learn, and definitely let's celebrate together. We're in a really interesting period of time, and we're excited about the journey that we're on, and the people of Ontario, every single one of them, deserves to have a place where they can get access to care. They deserve an ongoing relationship with a primary care clinician who will care for them and their families over a lifetime. And that's what we're in the process of building. Thank you very much.
Wow, I started off with optimism and now even more so, Jane. That was an amazing talk and an amazing story of, I would say, seizing the moment, being a driven and forceful leader who's really demanding of yourself and of others that we reform that kind of cottage industry that primary care has been for many, many years, and force it into a system, which is actually what we've needed for decades. So absolutely fantastic work that's taking place, and not letting perfection stand in the way of the good. It was a major theme for me as well. Fortunately, we do have time for questions, both in the room and online. So those of you who have a burning question, get up at one of the microphones. There are going to be people online as well, and somebody somewhere is going to cue me, Elliot, is going to cue me to the online questions. We do have a bit of time, which is fantastic, before our break. So we've got probably about 15 minutes or so that we can use. And so what I'm going to do is I'll start in the room and I'll ask you to introduce yourself briefly, who you are and your background, and then one question each, and to be fair to everybody, as succinct as possible. So we'll start over here on my right, and Elliot, I'll ask you to jump in whenever you need to with online questions as well.
Hi, Dr. Philpott. My name is Mary Huang. I'm with PERC, and I'm a patient partner. And my question is, how do you deal with the population that's very hard to track, the people who are homeless? And they're usually not attached. Thanks.
Thank you. We'll start with the hardest question of all, which is a really, really important one. So I would say I don't know that we have a perfect answer to that yet, but I want to give a shout out to some people. We're seeing some really fantastic efforts underway in various parts of the province. I'm sure I'm not aware of all of them, but finding ways to be able to reach people, including people without homes, is one of the strategies that we have tasked our Ontario health teams and their primary care networks to work on. As I said earlier, we use this Healthcare Connect waitlist as a province-wide matching tool, but we recognize that the people who need care the most probably don't find their way, or many of those who need care the most don't find their way to that list. We're seeing some really fantastic programs of outreach that are being held in schools, in neighborhood centers, in shopping centers, where people are trying to find out who is not attached to care and find gentle, supportive ways to bring them into an ongoing relationship. So I want to give a shout out to the Toronto East Ontario Health Team. I never remember their actual official title. Is it Toronto East or Toronto East Health Partners Ontario Health Team or something like that? They've probably one of the really great examples that we're seeing where they're working with schools and community centers to be able to let people know that they need attachment to care and to have essentially an interim health home where they make sure that it's as easily accessible as possible to those people who may not have homes but who may find their way to a school center or have outreach to the school center to say, you know, do you have a primary care home? If not, we'd like to help you to get one, take care of people for a short period of time, and then figure out where they can best be attached. And there are creative approaches to this happening everywhere across the province. I'm looking at Jonathan, who's dealing with an entirely different population up in the Renfrew area where they are setting up interim ways of people that don't have access to care and finding ways to say, let's not just have unattached clinics. I don't want to use the term unattached clinics. It's on a path to attachment clinics, or maybe you can come up with a better name. But when you find people that don't have access to care, give them care when and where they need it, and then say to them, how can I get you into a relationship with someone who could be the person that you can always go to, them and their team, and we'll take care of you until we can, in a warm and friendly and safe way, make sure that you are connected into a team that can provide that ongoing care.
I'm not sure if you're aware of Dr. Andrew Bosworth from University of Network
Yes.
Social Medicine.
Yes.
And he's coming to Ottawa November 13th to talk about Downhouse, and we're having a conversation with homelessness. So, and some fantastic staff because they actually have a ER and hospital. So
Yeah.
I think like the staff's most supportive housing are not being provided.
Yeah, excellent. So I don't know whether everybody heard that without a microphone, but she was speaking to the Dunn House project that Dr. Buzari and colleagues have developed at UHM, which I think is a fantastic and interesting model that we need to think about how we can adapt that model across the province in other ways.
Thank you, Dr. Philpott. That was the work you're doing is amazing. My name is Amanda. I'm from Nossum University, a research associate there. I'm a board director on my community health center as well, and that's kind of relates to my question too. So I'm trying to rationalize how the provincial government was able to put out this legislation mandating primary care while also putting out legislation that caused the closure of safe consumption, safer supply sites, and essentially is criminalizing mental health and addictions. And we know that that's a major healthcare issue, and these site closures just exacerbated that issue as well. So are those conversations that you're having with Premier Ford and his government?
Thanks for the question, and thank you for the work that you're doing at Nossum and also in your community health center. That's a really fantastic way to be able to contribute. What I would say on that is we're having some really interesting conversations around the links between primary care and mental health and addictions care, which have kind of existed in pretty siloed situations up until now. I think what I can say that I think is the most sort of optimistic way to frame this is I think there's an opportunity when we're shining a light on primary care to say that a form of primary care is mental health primary care and substance use primary care, and be able to bring that together, whether it's actually physically co-located places or whether it's wrapped together in the same system so that we work with people with mental health challenges or addiction and introduce them to primary care and then link that into the primary care team. So I think there are ways to address the concerns that you've got under the umbrella of primary care, and hopefully that's one of the things that we're going to work on in the next months to come.
Elliot, are there any questions online?
Toronto Partners. Is it on? Okay. Yeah. Patrick Fang from the East Toronto Partners Group said, now that PCAT funding is rolling out, what do you see as the biggest challenges for PCNs and OHTs to implement their plans and achieve success on the ground? And then what research tools or supports would be the most helpful for addressing these challenges?
Wow, great questions. Okay, so how, what's the way that OHTs and PCNs can be the most helpful? Let me just first of all say, one of the reasons for my optimism right now is that, I graduated from medicine over 40 years ago. I have seen this province go through a lot of iterations of organizing itself for healthcare. What I have seen is that many of them have failed in significant part because they have not engaged frontline clinicians, and particularly physicians, I think it's safe to say. So some of you remember Health Links, for example. There was so much energy and enthusiasm, and Health Links was going to solve all our problems. And I remember in York Region when I was Chief of Family Medicine at the time, and after the whole program had been developed way along the way, I was at a table where the group was organizing it, and they were like, how come doctors never come to our meetings? I'm like, well, first of all, your meetings are in the middle of the day when doctors are seeing patients. Second of all of you are being paid to sit at this table, and the doctor comes to sit at this table is not going to be paid to sit at this table. And I kind of went down the list. But they then wondered how they could solve their problem and get the physician engagement. The fact that we've got OHTs who have to have a primary care network, and in my mind, a primary care network is all of the primary care clinicians who are on the ground need to be invited to participate, encouraged to participate in those primary care networks, and they need to feed in to the OHTs to develop the plans for primary care, and they need to be supported to do so. And that is why I think the wave that we're on right now can be successful, because of that linkage there. The second part was about research and what we need. We need all kinds of research, and if you want to talk to the biggest champion for research in the primary care action team circle, it would be I'm a big champion, but Liz Mugga always outdoes me. She is brings up research at literally every conversation that we have. How are we going to make this into a learning health system? Liz is always saying. So I would say one of the biggest needs we have is helping us learn as we go. We've got a lot of pieces in place to do that. We have lots of small cycles of improvement. But the more that you can help us look at the teams that are being developed, figure out what's working, help us be able to rapidly improve our approach, I think any of those sort of implementation science pieces would be extremely helpful.
Great, thanks very much. Walter Wojcicki, University of Toronto. And I admire everything you're doing. It's certainly making great progress. And I'm going to pick on this physician engagement element that you just mentioned, because I think you're correct. Many of our past initiatives have failed because we failed to introduce this, and I always said Ontario health teams will move at the pace of physician engagement in that model. That's how they're structured. What are you learning from across Ontario about that process, or best practices in that process? I unfortunately think to get to 10,000 physicians, we can't rely on you visiting them all with coffee and donuts. Are there strategies that you're seeing employed? Because when I talk to physicians, some are very keen. Almost everybody in this room is already sold. But many of them are reluctant and distrustful of anything that the government might have to say, irrespective. How are you learning about that? Because that will be needed to be solved in this process.
Thanks. What a great question. It is a huge part of the challenge, because it's a massive workforce that we're trying to engage, right? When you think that we're somewhere between 14,000 and 17,000 family doctors across the province, depending how you count them. And then, beyond them, all of the primary care teams, the thousands of nurse practitioners who have become essential parts of primary care teams, et cetera. And how do you actually get a voice out to them? We've had a lot of conversations about how we can do this better, and we're trying to use the tools that are available to us, including some of the associations, both the Ontario College of Family Physicians, the Section of General and Family Practitioners, et cetera. But even they struggle, of course, to get the messages out. So I would say that is something that we could definitely use the help of this room. I was actually speaking to Danielle last night about particularly how can we reach young clinicians and new graduates, new nurse practitioners and new family doctors. I really worry that as the government continues to ramp up training, and there's going to be a 67% increase in the number of family medicine residents that are graduating by 2028. But if we are seeing programs, and there are programs in this province that are graduating entire cohorts of their family medicine residency programs, of whom none are going to join or start a comprehensive practice over the next, in the first few years. That is the group I am desperate to reach out to say, what is it we need to do to build a system in which you will want to become, at least in part of your career, a comprehensive general practitioner. So we are, I would say I don't have the answer yet as to what that is looking like. I'm asking people like Danielle and other chairs of family medicine to help me figure this out so that we can make sure that they know, first of all, hope is on the horizon if it's not at your doorstep yet, that there are supports that are out there for you. We think that what we're building is going to make your conditions of work better, but we can't be sure unless you tell us what it is you need. So I think it's a great question to which I still need to work on my answer.
Elliot, do we have other questions online?
Let's go with Lisa and Iman, and then I'll take one from the.
Hi.
Lisa and then Iman.
Is it okay, Emma? Okay. Hi, my name is Lisa Jacquemin. I'm a family physician here in Toronto and at the University of Toronto. I'm also a scientist at ISIS, and I'm leading Poplar. So I really liked your example, very inspiring, and a very wonderful example of how you use data with the Healthcare Connect, the number of phone calls your team is making and getting people off the list. So my question is very predictably about data. You know, we hear a lot about analyses, and there are beautiful examples of many, many good studies done using very rich data, but we're so challenged in truly getting primary care family medicine data that represents the work that's happening at the ground level with teams, with members of the team, and we're working really hard to do this. And I thank the government for supporting some of this work in doing this. But we need the government's help. We need to get a bit more buy-in on the importance of getting not the traditional, health administrative data that's well-oiled machine. Definitely qualitative work is extremely important. It's done by many of my colleagues here, and they're the best in the world. But we do need EMR, family physician data, low-hanging fruit, and we need help. And where's the government, other than thankfully helping us try to do this, but is it on the agenda to sort of provide data?
So first of all, thank you, Lisa, for the work that you're doing and taking on the leadership of Poplar. It's very exciting. We should have an offline conversation about some of the stuff that's going on. But a couple things I will say is, there is a lot of data out there, first of all, that doesn't get used or doesn't get gathered in the right way, doesn't get to the people who can actually do something with it. So we've been having some interesting conversations about the things that teams have to report, for example. They have to report, and the reporting burden is pretty high for a lot of primary care teams, but that information doesn't always get used in helpful ways. So I think one of the things we need to do is what is the data we're gathering that we're not using, and if we're not going to use it, then let's stop asking somebody to deliver it to us, and what is the more important information? So we're doing a bit of work looking at that. In terms of the actual clinical data, it is absolutely on our minds, and we are working on a plan to be able to figure out how to make that better. I would say, when I talked about the 3 pillars, which are all kind of moving forward, but they're moving forward in different paces, and the digital we deliberately sort of slow started on, but we are in a ramp up mode as to the digital data piece of our plan, and have some ideas as to how we can do better to connect that data. And I spoke about the fact that most EMR data does not go into the provincial electronic health record, for example, for a whole bunch of reasons. I am on it. We are going to figure this out.
Great, that's wonderful. Thank you.
So with apologies for those waiting for questions, so Iman, maybe you can come up and grab Jane individually right after we finish, but we are right at time. It's impossible for me to summarize this fantastic talk and this fantastic work. The driven leadership that we have with Dr. Philpott is amazing. It's absolutely unbelievable. And rather than summarizing her talk, which I can't possibly do, I just want to ask you all for another round of applause and support for the leadership that we have to do this important work. We now have a 15-minute break, so we're going to be back in this room at 10:45. Those online, we'll see you back here at 10:45 for the plenary oral presentations. The plenary orals are spectacular. You can see them on your program. We've not always done this every year at Trillium, so this is an amazing opportunity. Those of you who want to can visit posters on the mezzanine level in Willow East and Willow Foyer. Concurrent oral presentations that come later will be divided between other rooms, so there'll be transitions. So we're going to take a break till 10:45 and ask you to come back to this room at that time for the 4 plenary talks. Thanks very much.